Yes.
So welcome to this webinar on the Rare Disease Day 2024. So as a celebration, we have the pleasure of having with us Professor Toscano, who's going to talk about rhabdomyolysis. This is a webinar that is part of the muscle group webinars thematic month that started in January. And it's a rather important subject, as you imagine. So Professor Toscano basically doesn't need any introduction, but for those who may not know him, which I find a bit difficult to believe, is professor of neurology in the University of Messina in Italy, and he has a great amount of titles and occupations. I won't talk about his past because everybody knows the amount of publication he has had both in recent and more remote years, and not of all his titles because he has too many for me to name them down here in a few minutes. He's been a very precious collaborator of the European Reference Network for EURO-NMD for the last years, and is also a distinguished member of the faculty that is part of the European Academy of Neurology, where he has very important roles in the educational and training branches. Is a very well-versed neurologist, not only in neuromuscular diseases, but also and mainly and namely in neuromuscular diseases, both metabolic, genetic conditions, peripheral neuropathies, and all the expectable amount of diseases in these areas that he's an expert. He also has a soft spot for neurodegenerative diseases, which is a rather interesting thing because many of our neuromuscular diseases have also a neurodegenerative component associated. So without further ado, I would like to pass on the word to Professor Toscano. Thank you, Antonio. The floor is yours.
I also would like to thank you for these very kind words, dear Antonio. And I'm very glad that my talk is on the day of celebration of rare disorders. So it's a very important day for all of us and for all the patients and associations. So my role is today to talk about the phenomenon of rhabdomyolysis, which is something that's still under definition. And I'll start just with some definition because you know that it's difficult sometimes to strictly understand the difference between hypercemia and rhabdomyolysis, but hypercemia is usually considered as a persistent or recurrent elevation of serum CK, and this could be considered a borderline value like 5 times the normal values, or defined after over 5 times the normal values. But rhabdomyolysis usually is expected as a very high value of CK, much more than the usual hypercemia. And there are several different interpretations I'll show you in a minute. So we personally in our group, we consider rhabdomyolysis a phenomenon over 4,000, 5,000 units per liter, with a peak within 24 hours. And usually there is a quite rapid and progressive decrease by 30–40% per day after the initial value. So in few days, usually the patient is able to recover. And something that is really cool, a side effect of this is the myoglobinuria, intended like dark urines or in other kind of expression like Coca-Cola-like urines because of the color. And this is considered when myoglobin is persistently present over 250 mg per mil. So I said that there are different interpretations about the value that define the rhabdomyolysis. So for example, Benedict Schoser and collaborators a few years ago defined like uh, uh, rhabdomyolysis when you have values over 1,000 of a unit per liter. But this is something that has been arbitrarily decided, as well as, for example, in this very large group of patients studied by the group of Nicole Vermans. So you see that they talk about an acute CK level exceeding 2,000 of unit per liter. So there is a large number of interpretation, but what is really relevant is that usually there is a very important damage of the skeletal muscle. So we, at the moment, are very busy with the definition of hypercemia guidelines, and we are quite happy with the work we are doing. And we think that in a few months we will have the definition of the asymptomatic or oligosymptomatic hypercemia, and this is a very strict link to the story of the rhabdomyolysis, because once we have defined this, it will be even easier to define the more exactly the limits of the rhabdomyolysis. This is the task force that is interpreting the and trying to define the guidelines for hypercemia. And going back to the pathophysiology of the rhabdomyolysis, you see that there is a number of severe phenomena that are, for example, the alteration of the sodium-potassium ATPase pump. There is a calcium influx in the cell, and there is a protease activation. This led to a membrane destruction. Membrane destruction in muscle cells means that the muscle cells is going to die, and this is also involving mitochondrial damage and the phenomenon of the apoptosis. So this is basically what happens in the before to define the increase of CK as a rhabdomyolysis. But there is a sort of a cascade that is summarized in this slide, and you see here the first move is the break down of the skeletal muscle cells. After a crash or other physical injuries, you can get damage of muscle cells directly or even interfering with the blood supply, so that the muscle cells is devoid of a specific and adequate blood supply. And when the muscle tissue is damaged, rapidly fills with fluid, including sodium ions, muscle fibers are subjected to disruption, and there is consequently a rise of intracellular calcium ions. So this is can provoke a swelling of the cells and the continuous muscle contraction and depletion of ATP, leading to the final breakdown of the cells. And also, in addition, after the disintegration of the cell, neutrophil granulocytes enter the muscle tissue and can produce an inflammatory reaction, releasing the well-known reactive oxygen species like ROS, particularly after a crash injury. So this has been mentioned in this specific paper done by the group of Patrick Torres, and you see here there is in this graph, in this table, there is a sort of a summary graphically represented of what happened before the rhabdomyolysis. So you have different causes, like, for example, metabolic causes or thermodependent syndromes, as well as trauma or toxins, or also iatrogenic causes. You can see there is a very large number of different mechanisms that can lead to the calcium influx, the apoptosis, the mitochondrial dysfunction, the hypercontractibility of the cells, and the alteration of DNA, lipid, and proteins, all leading to a deficiency of the ATP production that can produce the damage in the muscle cells and consequently rhabdomyolysis. But what we usually see when the patient is suspected of a rhabdomyolysis, there is a sort of a group of accompanying signs and symptoms. For example, excessive fatigue or exercise intolerance, myalgia, muscle contractures, because we consider in this specific situations contractures, not cramps, because you know that contractures are related to the ATP production or deficiency rather than cramps that are more subject to neurogenic causes. Myoglobinuria, so the dark urines we have already mentioned, and in the longer term, muscle weakness. But this is not all, unfortunately, but because after the start of the rhabdomyolysis, there are several other complications of the rhabdomyolysis, like, for example, the acute kidney injury, which is usually a direct effect of the delivery of the uncontrolled delivery of myoglobin, hypovolemia. There should be later some phenomena like disseminated intravascular coagulation, but also there is an imbalance of electrolytes like hyperkalemia, hyperphosphatemia, hypocalcemia, leading to the complication like hypovolemia, and I would like also to mention the compartment syndrome, which is a very peculiar situation where the muscle cells are subject to the ischemia and fluid sequestration, and I'll show you a case in a minute. So if you take all the causes of rhabdomyolysis, you can have two main different group of disorders, like genetic disorders that are characterized by metabolic muscle disorder, mitochondrial disorders, although quite rare, and other kind of muscle diseases. On the other side, you can take in consideration acquired causes, like after use of drugs or toxin or ethanol, or after an extreme physical exercise, or after a crash injury, or after a so-called compartment syndrome, we'll see. It's very important also to consider the ischemia and the metabolic alterations in the causes of rhabdomyolysis more than we thought, and also the practice of anesthesia may provoke some rhabdomyolysis in specific patients. So if we can consider the mechanical causes of rhabdomyolysis, we have to take in consideration, as we mentioned, the crash syndrome or the compartment syndrome, or an excessive overuse and an overuse of the skeletal muscle, or electrical injuries. And here, I just would like to show you the characteristics of a case report that was where a man of 55 years old was involved. The day before the admission to the hospital, he had a very intense physical exercise, biking, I can tell you, and for several hours after this exercise, it was impossible for him to normally walk because of rigidity, muscle weakness at lower limbs, and myalgia. So he came to the hospital, and the CK was representing a rhabdomyolysis, 6,500 units per liter. And he also noticed that the urine were dark urines, very Coca-Cola-like colored. So what we did at that time, so we thought there was a clear case of rhabdomyolysis with myoglobinuria, and we started to study him, and the electromyography was normal. We didn't think of muscle biopsy because we wanted to wait a little bit to see what was the clinical situation in the a little bit later, but we performed the muscle MRI of the lower limb. And you see here at cuff level, there is a quite large edema, especially in the external area of the muscle, very prominent edema. And we decided not to perform a biopsy, but to wait and to hydrate him, very high hydration with the use of diuretics also. And the diagnosis, the supposed diagnosis was a compartment syndrome. And I'll show you why. So again, at thigh level, still edema, but a week later, the edema disappeared completely, and after 5-6 days, he spontaneously recovered with disappearance of symptoms and normalization of CK values. So this confirmed our suspect of a compartment syndrome. You see here in this interesting vignette that compartment syndrome, especially in the anterior compartment of the lower limb, is characterized by the compression of vessels by an increased pressure by muscle cells. One, the capillaries are not functional, and the muscle cells are suffering, or they can also die later. And in some cases, hydration and diuretics are enough to recover, but in other cases, you really need an incision of the skin to try to release the pressure of on the muscle cells and on capillaries. So in this case, you can recover even earlier, but it's not necessary in the majority of cases to use a fasciotomy. But let's take the non-mechanical causes of rhabdomyolysis, and consider that one of the major recurrent causes is the muscle dystrophies. Not specifically Duchenne or Becker, they can also show rhabdomyolysis, but other kind of dystrophies like limb-girdle dystrophies. Here an example. This is a not very recent, but still significant paper by Margherita Mirone's group. And when they studied a number of 13 related patients, they found that 6 patients with rhabdomyolysis had the fucotin-related protein deficiency. So there was this kind of muscle dystrophy. And this was also the subject of this work done by Japanese authors, where there was an aggregation of causes. Not only the presence of a Fukuyama congenital muscular dystrophy, but there was a complication done by an infection by Coxsackie virus, and this was these two, Coxsackie A4 virus and the Fukuyama congenital muscular dystrophies, were two aggregate causes of rhabdomyolysis in this patient. But again, this is a large group of patients, over 500 patients we studied some years ago with the collaboration of the group of Naples and other colleagues. And what we found was that surprisingly, there was a quite important number. We saw among them four patients with ANO5 deficiency And you can see that in the boxes with the red border, with the red outlining. So these patients were practically asymptomatic. So some of them had also myalgia or cramps or contractures, I would say, but the CK level was very high. And these were patients with a sort of pseudo-metabolic myopathy, which is quite often recurrent in anophyte deficiencies. Malignant hyperthermia is another cause, and you know that there are some patients that have an autosomal dominant trait with a family history positive. Specifically, this kind of disorder is triggered by general anesthetics like Allotan or succinylcholine. And what is the characteristic of this situation is the muscle rigidity, weakness, but very intense hypercemia with rhabdomyolysis. And this is a really very worrying situation for the patient, and they really need to have a dantrolene sodium intervention to be saved in case. Several patients with the autosomal dominant malignant hyperthermia have as main cause the defect, the mutations of the gene for the ryanodine receptor, RIR1. And this has also been studied, largely studied by this very distinguished group of colleagues from Germany, Netherlands, Belgium, and they found that in a cohort of 77 non-related patients, there were many patients that had either the dominant form, in other words, the malignant hyperthermia susceptibility, or also other kind of congenital myopathy with the recessive trait, and they all had rhabdomyolysis. And let's take the likely most recurrent causes of muscle disorders, which is included in the metabolic myopathies. And when we talk about metabolic myopathies, we talk about glycogen storage disorders, we talk about lipid storage disorders, but also mitochondrial disorders. And we know that glycogen and lipid metabolisms are more affected and more prone to muscle cell damage rather than mitochondrial disorders. The final way is the production of ATP, which is deficient in these situations. And when we consider metabolic myopathies, we have to take in mind that we have two different forms. One is the dynamic form, which is characterized by exercise intolerance, contractures, myalgia, of course, rhabdomyolysis and myoglobinuria. And the other group is usually characterized by fixed weakness. And you can see that there are several different kind of deficiency, either in the field of glycogen storage or lipid storage, and sometimes in the caused by respiratory chain defects that are differently represented from the dynamic or chronic form. This is a representation of the glycogen storage disorders. You can see that the red spots characterize different kind of deficiency, and the rhabdomyolysis is quite recurrent in this kind of disorders. So likely one of the most recurrent disorders characterized by rhabdomyolysis is McArdle disease or the myophosphorylase deficiency. So this kind of disorder is characterized by exercise intolerance, sometimes since adolescence or even from the infantile age, exercise-induced muscle pain, contractures, recurrent rhabdomyolysis and myoglobinuria, So this means that CK is very often elevated. And something that really can give us some addresses for the diagnosis is the presence of the second wind phenomenon, which is characterized by a brief recovery of the after a stop of the muscle activity after a brief rest and myalgia. So the patient after this period can start again to move with no specific problems. But in addition, myocardial disease is also characterized by a different form, which is where this fixed muscle weakness is present. And more often, this kind of form is present in older patients. So this is the table that represents what happens usually in the cell with the anaerobic glycolysis working. So normal cell is able to break down the glucose and to supply the ATP production. But in myocardial disease, where myophosphorylates is not able to allow the breakdown of glycogen, there is a deficiency of the ATP production and no energy enough for the cell to survive, and there is a very severe damage of muscle cells. And on this purpose, this is a case report. A male since childhood complained for fatigue, excessive fatigue, exercise intolerance, and myalgia after exercise. The blood test was incomplete, but showed a high level of transaminases, but with no hepatic involvement. CK was not measured at that time, but several years later, when there was the measurement of CK, there was the evidence of rhabdomyolysis, even over 2,000 units per liter. And after several years, he understood that there was something wrong with his muscles, and he was able, in any case, to recover after a brief resting period. So the neurological examination normal, but when we performed the forearm test, there was no increase of lactate, which is very common for this kind of disorder. The muscle biopsy did not show any staining for myophosphorylase, and diagnosis was there. So he had a myocardial disease. This was confirmed by the measurement of their enzyme activity was very, very low. So less than 1% of the residual activity. And again, confirmed by the molecular analysis where there was the most recurrent mutation that was homozygous in this patient. Then if you go to the other end of the terminal glycolysis, you may see patients like this, but unfortunately, I can tell you that the recognition of this patient is quite rare. This was a 44 years old man, born from consanguineous parents. Since his 20s, he had several episodes of myalgia, contractures, and fatigue with dark urines. At 42 years of age, he had an episode of acute renal insufficiency with anuria, myalgia, and muscle weakness after a strong exercise, physical exercise. And when measured, the CK was enormously elevated. So it was 214,000 units per liter. So in fact, he needed a very urgent very urgent cycles of dialysis to try to restore the renal function. When he was a little bit better, he was referred to our centers, and we found that the neurological examination was normal. This is important because this doesn't rule out, of course, kind of metabolic, muscle metabolic disorders like this case. In fact, the electromyography showed a myopathic pattern, and there was a very reduced lactate rise after the exercise, like the exercise for the forearm exercise. Muscle biopsy was unremarkable, as you can see. Either the hematoxylin eosin or the PAS were not affected. But once we measured the single activity of the enzyme of the terminal glycolysis, we found that there was only 20% of residual activity of beta enolase. And this was later confirmed by the gene testing that confirmed the ENO3 mutations. It was a family segregation, in this case, other members of the family were heterozygous. And going back, we knew that there was only one case described by the group of Professor Cohn and Professor Bresolin at the beginning of 2000. And we described two cases. One was from our area, from Sicily, and another one was sent to us, was a Turkish patient sent to us by Roscoe in Levan. We measured in both cases the activity of the beta enolase that was deficient in both cases. So if you look at this table, later we studied from the pathophysiological point of view with the group of John Bissing, these patients, and what we found was that there was all of them, apart from the first case, had rhabdomyolysis, very high rhabdomyolysis. And there was a real difficulty for them to prolong the physical exercise. They had very limited resources to bike, for example, when exercised. And this was very similar to the results of patients with phosphofructokinase deficiency when exercise. But now we have to change completely the area. So we have to refer to the lipid metabolism. And you know that there are different categories of lipid metabolism deficiencies, but I would like to point out particularly the first two. So the free fatty acids, mitochondrial transport, the mitochondrial fatty acid oxidation. In these two categories, you can find two specific deficiency like CPT2 or carnitine palmitoyl transferase 2 deficiency, or the very long chain acyl-CoA dehydrogenase, so-called VLCAD deficiency. So these two disorders, CPT is more recurrent rather than VLCAD, but the characteristics of both are very similar. If you look at so this is just to show you that once you have deficiency in some of the components of the lipid metabolism, there is a lipid storage in muscle cells, which is sometimes very important. And those two are the different situation from the neonatal form to the adult form. And you see that the adult form is characterized by rhabdomyolysis and exercise intolerance and myalgia. Other important clues for the investigation of this patient: serum CK very high during attacks in CPT2 VLCAD disorders. Important to study the urinary organic acid, because very often glutaric acid is increased. It's important to measure carnitine free and total measure, because it could be reduced in this kind of disorders. But what really can orient our diagnosis, the study of the profile of plasma acylcarnitines. So they are very sensitive to, according to different numbers of the formula that compose the plasma acylcarnitine profile, can orient to different kind of disorders. CPT2 is one of them, and this CPT2 deficiency can be characterized by fatal form, infantile form, especially the adult form, which can show muscle pain, weakness, and myoglobinuria apart from rhabdomyolysis, especially when triggered by very intense exercise, fasting, or fever. VLCAD, so vein chain acyl-CoA dehydrogenase deficiency, is very similar from the clinical point of view, recurrent rhabdomyolysis and muscle weakness after exercise, fasting, or cold exposure. So it's really difficult to understand which is which, and we really need now to study the acyl carnitine profile, but especially the genetic testing can give us the solution of the cases. And this, what is important is management of this kind of disorder. So we do not have specific drugs to try to contrast this kind of disorders. Somebody in the past are using benzafibrate, but with no brilliant results. And it's important to educate the patients that they need to avoid fasting, they need to avoid stressing exercise, and they have to try to use a high carbohydrate, low fat diet. So this could be very important for their quality of life. But let's go to the practically most relevant disorder in the lipid metabolism, which is the multiple acyl-CoA dehydrogenase deficiency, very rare autosomal recessive disorder, and this is characterized by the alteration of the flavoprotein dehydrogenase that are strictly linked to the mitochondrial respiratory chain. So once you have a dysfunction of either electron transfer flavoproteins or its dehydrogenase, you can have an abnormal lipid storage and very relevant clinical alterations in this kind of patients. So you can have a neonatal onset form, but you can have also a late onset form. And they are characterized by exercise intolerance, muscle weakness, dysphagia, dysphonia, rhabdomyolysis, of course. And when you study the neurophysiological aspects, you may have different responses. So electromyography can be normal, can be myogenic, can be neurogenic. So this is not addressing our diagnosis. We know that usually the CK is very elevated, but if you perform muscle biopsy, you will find that muscle fibers are containing a very high content of lipids, lipid droplets especially. But what is a good response is that they respond very well to riboflavin treatment. And on this purpose, I would like to show this case. There was a 28 years old man. Since 1 year before coming to our observation, he complained of exercise intolerance, mild weakness, ache for limbs, contractures, and 2 months before coming to the hospital, he developed important dysphagia, dropped head, difficulty in walking and standing, and he also lost several kilos in 1 month. And when we examined him, there was a real severe muscle wasting with dysphonia, dysphagia, eyelid ptosis, and very important muscle weakness of the neck muscles, axial muscles, and proximal muscles at forelimbs. So the EMG was myopathic, and once we performed the muscle biopsy, it was a very relevant lipid storage. So we measure also carnitine, that was very low, and as you can see that there was a clear rhabdomyolysis with very high levels of CK, but also other enzymes as transaminases were quite high, as well as myoglobin. And this is the result. So we diagnosed a vascular myopathy with lipid storage, and we started to use carnitine and especially riboflavin, 200 mg every day, oral riboflavin. And you see, this is the patient. Very difficult for him to raise the head from the pillow, to protrude his tongue, to raise arms, really, really very highly suffering. Yeah, this was the maximum he was able to do. And after 7 days of riboflavin and carnitine, the laboratory values were nearly completely normalized, and he had a very important recovery. So no dysphonia and dysphagia anymore. Muscle strength dramatically improved. And you can see here is the patient a week later, so able to walk and in a quite good shape, I would say. And this was, it's important because once you diagnose this kind of cases, you can really save their life. So the last part, I would like to concentrate on iatrogenic disorders. You know that there are several drugs that can interfere with the muscle metabolism and producing rhabdomyolysis. Of course, we know that statins are very frequently involved in this kind of disorders, but other kind of myopathies can be generated by use of drugs, and you can see here a large number of different causes like statins, fibrates, or antiviral like zidovudin, or other kind of drugs like amiodarone, rucoroquine, colchicine, vincristine, and others. But let's see, this is a very large uh, table including different kinds of statins, different kinds of anti-lipid agents. You can see, for example, here like profibrate or bezafibrate. Other psychiatric agents, so substances that can create abuse like alcohol, cocaine, and others, but also other kind of drugs you can see here, like some antibiotics or other kind of drugs. So going back to the statins, we know that statins are very important in the prevention and treatment of hypercholesterolemia and coronary artery disease, but the statins can interfere in the generation of coenzyme Q10 production. And this has been demonstrated largely, and also the other end story is that there is a difficulty in producing ATP, and this can, of course, affect muscle fibers. And this is sort of a different aspects of the use of statins when they produce side effects. See that there are very mild side effects, for example, when we consider this classification by Alfirevich, which is now a little bit older. CK elevation, only myalgia, myalgia not tolerable, severe myopathy, rhabdomyolysis, or even in a specific case when there is the production of antibodies that can produce a very important necrotizing myositis. So all these are complications of use of statins, but the number of course, of this complication is quite low, luckily. And this is sort of pyramid reproducing different stages, like the less dangerous, like only myalgia or myositis, myopathy, but also rhabdomyolysis is one of the highest levels of the side effects of statins. There are some concurrent causes to provoke the statin-induced myopathy, like, for example, the sex, female more than males, increased age, renal insufficiency, hepatic insufficiency, and there are specific genetic predisposition to this kind of side effects. And there is also the possibility to try to somehow recover from this problem, because if the statin side effects are very low, you may decide to continue the administration. But if there is a rhabdomyolysis or the myalgia is intolerable for the patient, you really need to stop it, or to restart with another kind of statin, or restart with a very low dose of the initial statin. So there are different possibilities. But in the last years, we had the problem of the COVID pandemic, and some cases have been reported characterized by rhabdomyolysis and facades, like this case where the edema at the lower limbs is very clear in these photos. And just to conclude, some specific and practical addresses from the American Association of Surgery and Trauma. And you can see here they suggested a score to better interpret the rhabdomyolysis perspectives. This McMahon score is characterized by different scores, and if the score that takes in consideration several aspects like age, sex, calcium presence, phosphate presence, bicarbonate presence, if there is a score greater or equal to 6, this is important because the clinician should know that they really need to have a very high care of the patient because of high volume fluid resuscitation, for dialysis, even unfortunately in cases there is a risk of death. But luckily there is also some suggestion for the management of this kind of disorders, and you can see that there are several aspects that have to be tested, like first know if there is a population at risk, what are the clinical findings, what are the laboratory findings, what we can do to try to recover. So, for example, use of ringer lactate or chlorium or sodium chloride, just to integrate the situation and the hydration of the patient. We have to consider the urine output goals. I would say that the diuretics are from this kind of study, and bicarbonate are not particularly recommended, but we need to also balance the electrolyte abnormalities, to take in mind that we have to take care of the kidney situation, because sometimes you can have a very acute renal insufficiency, or you can have a disseminated coagulation, or the compartment syndrome. And this seems that quite useful tool to try to better understand what is the level of the rhabdomyolysis in terms of results of this McMahon score. So the final message is that when you have to deal with rhabdomyolysis, you have to be very careful, because you don't have to eliminate any cause. You have to take in mind that there are several causes, and you have seen that in some cases it's important to have an early diagnosis, an earlier therapy to save the life or to improve the quality of life of the patient. And I would like to conclude thanking my collaborators, especially Dr. Mattia Porcino, who has strictly collaborated for this talk. And I show you the Strait of Messina and the harbor of Messina. I hope you will be able to to visit this place. Thanks very much for your attention.
Thank you very much, Antonio. It was a very nice presentation and very pedagogic. As usual, people, if they have questions, are a bit on the shy side of it, and I'm going to basically try to fill in with some of my questions. And today I thought it would be a good idea to try to discuss vignettes with you based on my previous experience. So many, many years ago, when I was young and a trainee in neurology, I had a patient who had a seizure that was a focal motor seizure with secondary generalization. And to my surprise, it was not a prolonged seizure, and he didn't have a status epilepticus. He had a severe rhabdomyolysis and needed dialysis because his kidneys just stopped working.
Yep.
The patient had an unfortunate reason for this. He had a low-grade glioma very near the primary motor area. So obviously, and namely at that time where intervention was not very active for low-grade gliomas, the surgeons opted for a very more conservative approach, and later the patient developed a glioblastoma and died from it. But I was always puzzled by the initial presentation case. So because you showed in your table very well that a status epilepticus can lead to rhabdomyolysis, which is not surprising. But an isolated seizure, it's not exactly a status epilepticus. And I wanted to probe your experience in terms of if an isolated seizure is a frequent cause of rhabdomyolysis, and if not, what should I have looked for? Although, as you understand, the fate of the patient was much conditioned by the primary cause of his seizure.
So the first thing I would say that this was not a lucky patient, definitely. But the glioma, of course, generated the seizures, but there is no strict relation between glioma and, of course, hypercikemia or rhabdomyolysis. The rhabdomyolysis after seizures, as you have brilliantly outlined, is something that happened not often, but it's quite well known that you can find after a number of seizures a high level of CK. Mm-hmm. So I think in these situations, in my personal opinion, apart from the glioma, I always have the feeling that there is something that should be tested because you know that we have a great experience of, we all have great experience of double, even triple troubles, and it's not surprising that sometimes I did enough time, but one case sometimes I used to show is an old patient around 70. He was on statin since many years, and he had the rhabdomyolysis. When we performed the biopsy, we studied him very largely, and he had phosphoglycerol mutase deficiency, which was the base of his rhabdomyolysis, probably stimulated by statins, but statins use was not the real cause of the rhabdomyolysis. So in the case you mentioned, I reasonably think that the seizures were the cause of rhabdomyolysis, but who knows if there was something. So in the specific case, given the fact that the patient had also a glioma, it was difficult to insist looking for other causes of rhabdomyolysis. I can understand exactly.
Very well. Still no questions. I wonder if you want to comment on another case that I've seen more recently of a 17-year-old young man. So is a sportive guy who likes football since a very early age, probably by influence of his father. and the father said that he always had a very violent reaction to exercise. So sometimes when he was 5 or 6 years old and he went on those training or playing football, the father was forced to carry him on his shoulder, on his arms back home because he couldn't after that. It was a mix of pain and of weakness. And that was something that recurrently happened in his life. He was not very sure about having episodes of dark urine in those occasions. He probably had one or two at least. And he also had something that the father confirmed, that sometimes he would be very affected in the beginning of the game, and in the second part of the game or later in the game, you would be suddenly functioning much better. So things would improve.
Yes.
And so, as you imagine, the first thing I did was to ask for a CK that was normal, and the guy had normal force, and he had a normal 17-year-old fit, lean boy, and with nothing in special. And his lactate was also normal. There was no possibility of doing ischemia tests, and I was wondering, of course, what do you think in terms of this being, even with a normal CK and lactate at rest, some kind of metabolic myopathy?
Yes, I mean, the story and the recovery in the second half should suggest a sort of McArdle disease.
Yeah.
But, I mean, you said that the after the testing for lactate was normal. So I think that also other kind of disorders. But, see, the fact that CK was normal is referred to what after how many hours or days CK has been tested. Just after the match or late? Much.
Oh, no, this was completely off without any physical activity before. So
Okay.
we didn't test the CK with physical activity. It is going on still on investigation. I was just throwing this on the table to get your advice and hear about what you would do, or how you would orient the investigation next.
Well, the investigation in this case is to be very practical. I think you really need to get a gene testing, so you don't have to lose time because, unfortunately, I would say that we had cases of different kind of sportsmen and women. I remember, for example, a volley player, woman volley player had a CPT deficiency, but she was always fatigued. So she was for her for difficult to finish the match. There was no different situation from the beginning and the rest. So the alternative situation with the recovery is really seems to me I should think of McArdle disorder, but because now we don't use much muscle biopsies to look for the reason. So genetic testing is the easiest thing to do.
Yeah.
Difficult to say. For example, another group of disorder that have, as I mentioned before, pseudo metabolic form is the anoctamin 5 deficiency. This could be even something like that.
Very interesting, and thank you for your advice. Now that I was going to switch off, there is a question on the chat, so I'm going to read it.
Yep.
Is there any particular condition that would be suggested by two unprovoked episodes of rhabdomyolysis in a usually fit man in his 30s, also gives a history of episodes of unprovoked vomiting lasting several days? Question mark. Resting CK normal and not weak, no cannabis use.
Um, I didn't get exactly several episodes of what?
So he has rhabdomyolysis, two
Mhm.
episodes in the past, and he has histories of unprovoked vomiting lasting for several days, with normal CK and no weakness. And for some reason, the person asking is anonymous, but he or she adds that it's not a cannabis user.
Okay. Well, the clinical description is quite gives
Okay.
us quite a large number of possibilities. So starting from different kind of myopathic disorders, like for example, even uh, ryanodine receptor, for example, or metabolic myopathy. Again, um, today, if I have the possibility to have access to a laboratory test that use gene testing, I would I wouldn't lose time, and I should go for this. It's difficult, really difficult from this description to
Yeah,
better
pinpoint.
direct the specific diagnosis.
And I would comment that rise in lactate is a known cause for vomiting. That's what happens to athletes, namely to
Well,
swimmers.
well. Okay. The rise of lactate and vomiting are sometimes present in mitochondrial disorders, of course, as you definitely know. But for mitochondrial disorders, rhabdomyolysis is very rare. So it's not very recurrent. So even in mitochondrial myopathies, you have a very low increased level of CK usually.
Mhm.
So I would think of definitely for because of the recurrence of vomiting and high lactate of mitochondrial disorder, but it's not very it's very rare. It's ultra rare, I would say.
That's it. So thank you very much. It was a very nice occasion to have this exchange with you, and I have seen in the chat that the comments are very thankful and for your comprehensive talk and the way you have exposed your ideas. And we'll be very happy to have you very soon again, as you know, with us in another webinar. And so see you then. And thank you very much for this occasion.
Thank
Bye.
you very much to you and to all the ERN organization.
Thank you. Bye.
Bye.